Right. So what I've tried to do here with this one is combine our tummy stuff and our pelvic stuff. And so I don't break it up between the chapters. I kind of just flow through abdominal and gastric and then through urinary and stuff. We admittedly don't spend, I think, a ton of time on urinary, but it is a big portion of it, being able to differentiate it. Part of the reason I don't do that is we're going to talk about girl parts eventually, and we're going to have far more pelvic discussion, but we want to lay the groundwork now so you get in the wheelhouse of saying, okay, well, how can I tell the difference between, say, a kidney stone and an ectopic pregnancy and those kind of things. Now, if I was watching somebody else give this lecture, I would be telling them, hey, that was a decent job, you look very fit, however, don't do the first thing that you did, which is what I'm doing right now, which is to say this portion was my far and away least favorite part of paramedicine curriculum. Because basically what it says is, look, all these things that you got to memorize, all their signs and their symptoms and all the different organs and their locations, you can basically do nothing except for these two things. Treat for shock, treat for pain. And you're like, okay, well, if all I'm doing every single time is treating for shock and treating for pain, then largely distinguishing between these things are irrelevant, right? Ha ha ha, you stupid idiot. No, it is very important that you distinguish between all of these things specifically, despite the fact that all of your treatments are identical. Now let's do it. Now, one of the most important things that you can do is memorize where the organs are in your body, because there is a very clear parallel between the problems that they're having and the location of those organs, right? Meaning a lot of your problems are going to be discovered by simply saying, okay, well, if you're hurting in this area, what is the organ in that area? Because that's probably the source of your issue. So I start with the mnemonic glass in the upper right quadrant, knowing that the liver and the gallbladder are there. Knowing that just below that in your lower right quadrant is your abdomen, your appendix. And then on the upper left quadrant is most of the stomach and the spleen, and that's the GLASS acronym. Now, it's worth noting that there's not a whole lot in the lower left quadrant, unless you're a girl, in which case there are ovaries and fallopian tubes there. Now, admittedly, our ureters come down from our kidneys, right? Translating blood down the ureter, so that's there as well. That's why it's listed. But as much as I couldn't think of a way to fit colon and ovary and these kind of things into the GLASS acronym, there are still things down there. In fact, I don't want to say I get excited when somebody has lower left quadrant abdominal pain, but I am like, oh, okay, great. There's not a whole lot there that isn't these two things basically. And if you're not having urinary issues, the question becomes, well, is it digestive or reproductive? Because depending on where you grew up, those are very different experiences. So. And
once again, these are front-facing anatomical positions.
That's right. We're all kind of speaking from the anatomical normal, which means essentially our patient's right on our left and then palms facing up and so on. Mm-hmm. And so you have a bunch of questions that are just going to, on tests that are going to be filled with information, but ultimately just me pointing at a portion's body and being like, okay, if you know what is where I'm pointing to, then it won't be any of the other things, or at least it's incredibly unlikely. The tricky part is, not that I try to trick you in this way, but you can see things like how the liver kind of stretches across the midline. You can see how the stomach kind of goes vertical, not horizontal, and part of that goes into the right. So these are kind of a generic understanding of it. The pancreas is probably the greatest culprit. That is one I'll leverage. Now this GLASS system containing the GLASS, these 5 organs, isn't all the organs and all the associated problems. Of course, there are a million of those things. So put pretty simply, the more you know about that and the more familiar you are with it, the better off you'll be. But fundamentally, knowing the GLASS acronym and those associations is going to be the vast majority of what you're experiencing. Just don't be confused into thinking that it's all that's there. Now, it becomes super important to differentiate between hollow and solid organs, right? We have to know, essentially, which ones are which, and therefore what conditions to suspect an association. Now, we've got our first hollow organ, the stomach. Now, it doesn't mean that the organ isn't vascular. It just means in comparison to the solid organs that are way more vascular, okay, we have separation of issues there. Our intestines, whose primarily jobs are to absorb the nutrients and then water. Do you know which, is it small or large intestine's primarily job to absorb nutrients? Small, and it's the large intestine that's reabsorbing water largely. Now the bladder is going to store and excrete our urine, some waste products, and then we also have our gallbladder, part of our digestive system, that stores and excretes bile. But these are all hollow organs. Now, if I said, what's the main risk of a hollow organ, your response should be peritonitis. The main response to solid organs is blood. Now, can you bleed from a ruptured hollow organ? Yes. Can you get septic from a infected? Yes, of course. But the primary and motivating things for us is knowing that hollow organs, their big issue is that the rupture and leakage of those organs can lead to inflammation and infection and ultimately peritonitis. And your peritoneal cavity is kind of like your pleural cavity for your lungs in a sense. It's the lining of your abdominal wall. And the inflammation of that, listen to me when I tell you, is a surgical emergency. If you suspect peritonitis, it is go to the hospital time. This guy needs a surgeon. If a person has an inflammation and infection of their peritoneal cavity, something in their organ has ruptured or become so septic as to start dying. Okay? Peritonitis is severe. Now, one of the things that can kind of help us with this is the fact that it didn't happen all of a sudden. Little old lady falls down the stairs. She's now complaining of abdominal pain. I am in no way, shape, or form complaining of peritonitis. Now, I might if she said, what? Can you paint a picture that a person that fell down the stairs is actually having peritonitis?
It's like vague fever.
She had a fever before she fell, right? She had a vague description of pain and is not going to be indicative of peritonitis. And if I, for some reason, forget, remember peritonitis sensory nerves, because this is a huge point. Or if she had peritonitis and that's what caused her fall. There she was on her way to the hospital, she fell downstairs, right? She was so weak and dizzy from her peritonitis, essentially, she didn't have the wherewithal and she fell, right? But we have to kind of make this distinction. This is usually a gradual onset, not something that just, bam. And this falls neatly into the category of people where, you know, maybe they even have a hard time describing the situation. I don't know, my stomach kind of hurts. Okay, is that new today? No, it's hurt for a while. Okay, well, you know, I'll ask patients, are we going to the hospital today because something changed, or did you just decide enough was enough? And they're like, yeah, it was too much. Why would somebody have a rigid or distended abdomen secondary to peritonitis? Yeah, if they had a rupture, we want to kind of move away intellectually from the idea of bleeding. And so when I say rupture, I don't mean your organ is torn and now it's bleeding into you. I mean it's torn and now all your bile and digestive contents are leaking out of its safe pockets and it's infecting things.
I was going to ask if it could be from inflammation.
It is because of inflammation. Yep. You are getting a rigid board-like, consider that the lining of unlike your your lungs, your thoracic cavity that has a bunch of ribs, your abdomen doesn't. It's only tissue, right? And it's just soft and squishy, some more than others, admittedly. But if that's rigid and board-like and you aren't working very hard to maintain that, then chances are that the wall is inflamed, and this is a sign of infection, possibly sepsis.
Is there anything other than like hemorrhaging, black widow bite, or peritonitis that causes a rigid abdomen? Pregnancy stuff?
Yeah, distension, hepatomegaly, any type of, I don't know that I would ever describe it as board-like, like that's like registry phrasing for the peritonitis, but distended and taut, sure. But if you said board-like, I'm like, peritonitis, that's the words they use. But yeah, if you had, any type of ascites and distension of the abdomen, any type of fluid, but we also wouldn't be surprised to learn those people develop peritonitis very easily. So now we want to talk a little bit about our solid organs, and basically a little bit about their functions, and then also the concerns and associations we have with that. But again, this comes down to, if, for example, we talk about, we got any Arrested Development fans in here? Yeah? Solid as Iraq. Do you remember that line? Now, if we follow the glass mnemonic, essentially, that takes us over here, largely where the stomach and the spleen is sitting back behind there, what that means is if your person suffers an injury to the upper right quadrant of their abdomen, right, on the opposite side, we should not suspect splenectomy or a rupture of the spleen. Why? Because it's not over there, right? It's on the other side. And so again, a fundamental understanding of the anatomy can really help us. So if a guy's sitting there saying, oh, no, I don't know, it's like both sides of my lower stomach, and the question is maybe it's a spleen problem? No, very unlikely, right? We would be painting a far different picture. Now, I've got a picture about the spleen's location, but also one that I think kind of displays the vascular nature of it, and just kind of as a cross section is like, see what I mean? The thing is absolutely chock full of vessels. Does anybody know why the spleen is absolutely chock full of vessels?
Like the graveyard for RBCs.
Yeah, exactly. Because the spleen's primary purpose is to filter blood, so a bunch of blood needs to go through it. Now, there are some vague terms out there, because I think you could say filter blood for like half a dozen organs, it feels like. So I'm going to do my best to kind of simplify it, but when you do that, it kind of leaves some of the literal actual definition out of it, so pick your poison there. Now, the way I want you to think about the function of the spleen is that it largely filters erythrocytes, red blood cells, right? It also helps filter out germs, but for the erythrocytes, basically, like, it's often described as the graveyard for the red blood cells. This is where our damaged or our old blood cells go. They get identified as dysfunctional and then dismantled down into a whole bunch of things. Heme, iron, bilirubin, all kinds of things, right? The big one I care that you kind of maintain from or understand from this lecture is bilirubin, partly because it helps you associate jaundice. But anyway, the spleen says, hey, look, this red blood cell is past its prime. I need to break that thing down. And part of that is bilirubin. Now, it also works like a reservoir for blood cells, so it will store a bunch. And this is so if you have like an insult or injury, it can just draw from the spleen's store of blood cells, because creating blood cells, erythrocytes, takes some time. So basically, it dismantles the blood cells primarily into bilirubin, and also as blood flows through there, it starts exposing the pathogens to the immune cells to help fight. Now, on the right-hand side, we have a liver. And if you're keeping track, if I said, everyone point to your liver, every one of you should point to the upper right side, right? But as you can easily see in certain pictures, that thing spans all the way over. We are largely associating it with the upper right because that's where the majority of it is. Which means that if you take a bullet right through the center of your abdomen, could it affect your liver? Yes. What should you suspect, though? Right-sided abdominal issues, if anything, right? The liver's big, and in fact, by some metrics, it's about as wide as your hand, right? And so just up under those ribs sits this large, large organ, with your pinky being at the bottom of your rib there. So here again is an image of just how vascular this thing is. And if an organ is that vascular, what do you suppose one of its primary functions is? Well, something to filter the blood, right? Simply because that's where a lot of blood is getting channeled. Now, the liver doesn't just have these blood hematological functions, it also has some digestive functions. So the liver filters chemicals and toxins, no doubt. I don't have it on here. What else? Well, no, we'll talk about that in a bit. What do I mean when I say stores energy? What kind of energy, or how, or what? Glycogen. What is glycogen?
It's glucose that it's safe for storage.
That's right. Our body, if I eat half a Snickers, if I eat a whole Snickers and only need half of it, it takes the half I don't need and largely stores it as glycogen in the liver. What hormone allows it to be stored in the liver? Insulin. What hormone allows that glycogen to be processed out of the liver to become glucose? Glucagon, right? Now the liver produces bile, but that gets stored in a reservoir in the gallbladder. We'll talk about that one in a little bit. So the liver's reaction to the erythrocytes is it takes that bilirubin and it makes it water soluble and excretes it in bile. It's not doing anything with that as far as digestion goes. That's just the train it's taking to get out of you through your poop. It's part of the reason why your poop is brown in many cases, because the bilirubin is being converted into something that is brown. Now, when we talk about the kidneys, another solid organ, which, if you're following along, what's one of the main functions or descriptions of these solid organs I keep saying? Filter the blood, which means they're very vascular. So you suspect about the kidneys that if I show a cross-section of that, it's going to have a bunch of veins and arteries in it, right? It doesn't. No, it does. I'm just kidding. But I show this picture here for two reasons. Number one, because I want you to realize how far up your kidneys actually are, because I think a lot of people think they're much lower, but they're way up here, right? Largely, or mostly protected by ribs. But they don't, it's very difficult, I think, to find pictures where both the kidney and the liver are in the right place. And so the but what I'm trying to get across here is, look, the kidneys are way up, way higher than most people think, but they're still just below the liver. I say all this because, again, it is a quintessential thing to see a guy that's got a pole stuck in him and be able to understand what is happening with him based on the organs in the injury site that it's located. Yeah.
Well, some of these solid organs that are very vascular, like the liver and the spleen, so you like tear the lining of it or something, can you just bleed into that? Can it hold a lot of blood?
Are you saying if people suffer hemorrhages and it bleeds inside of that organ? Mm-hmm. I don't think so. Okay. I think the big concern is that if it bled inside itself, that it would at worst become engorged, which definitely happens. But the big issue would be it bleeding into the cavity. Okay. So I don't think you would hold enough blood in the tissue there to be a major concern, but it will cause dysfunction of the organ, and that would be a major issue. Now the kidneys are largely, yes, they still involve themselves with blood, but they are big fluid and blood pressure regulators. Now, I think we all know that it filters waste and then makes the pee-pee. Part of your bilirubin is broken down into another type of rubin I don't remember the name of, but guess what color it is? Yellow, right? Which is a lot of the reason why our urine is yellow. So why is it then, if I have liver dysfunction, could I become jaundiced? Well, what is the liver doing to erythrocytes? It's breaking it down into what? Bilirubin. And bilirubin is yellowish. Which means if I've got liver failure and my liver isn't effectively breaking things down, that bilirubin is not going to get... The spleen is breaking it down into bilirubin. It's the liver that's transporting it through the bile. And if the liver isn't doing its job, then bile is just floating around in us and collecting in our sclera, right, our eyes, and then also our skin, making us yellow. Now, if the liver is supposed to excrete the bilirubin through the bile, and that might make us jaundiced, why could it also be an indication of a kidney problem? Yeah, because bilirubin is also excreted through the urine. And so if your kidney isn't excreting bilirubin through the urine, and your gallbladder isn't, your liver isn't excreting bilirubin through the bile, then it's just building up. So if I see somebody with yellowed sclera or jaundice, I'm like, whoa, this is a liver issue. And he's like, nah, my liver's fine. I'm like, okay, then kidney maybe. But it's probably one of the two.
you said that the liver, I mean, it says, so it uses the bile to move the bilirubin out of the body?
That's correct. The bile is just a transport mechanism for the bilirubin.
Okay.
Well, it's not that it's just that. The bilirubin uses it for that. Bile is also helpful in digestion.
Okay.
But I had to do some research this morning because I was like, does bilirubin in any way help with digestion? It's like, nah, man, it's just hanging out. I'm like, oh, okay, that's just the mechanism of release. And that led me down a big path about understanding how bile breaks down in all of these different fascinating ways. And it's deep water. So put pretty simply, the kidneys, yes, they still filter. They filter waste. They make urine. They also regulate our blood pressure and our electrolytes. And in regards to those electrolytes, does anyone remember the word erythropoietin? Whew, we ain't gonna talk about it today. Don't worry, you're safe. This is a safe space. Put pretty simply, the kidneys initiate creation of red blood cells, and that's where we're at. Now, the fundamentals of what I want you to be able to understand about these organs is this. Is there a million billion other things to say about it? Yes. Can I say any of that? No. This is mostly what I need. Old red blood cells go into the spleen and they get broken down into a lot of things, admittedly. One of the things I want you to know about is that they get broken down into bilirubin. That bilirubin goes into which organ? The liver, right? The bilirubin then gets transported by bile into your intestines where it's excreted as waste, but it also goes into your kidneys where it's excreted as urine. So really what we're kind of tracking here is less about the blood cells and more about bilirubin. What up?
In regards to the kidneys, how do they regulate electrolytes and blood pressure? Because I know electrolytes can be absorbed or excreted through.
Yeah. I was talking to a paramedic recently. His wife was in my first EMT class, and he asked a question to her about one of the calls he was on, and she said, well, it's the RAS system. And he was like, what the hell's a RAS system? And she's like, the renin-angiotensin-aldosterone system. And he was like, I don't know anything about that. And she was like, I got taught that in EMT class. And he was like, well, my first year we taught a lot. But the answer to your question is the RAS system, and we're going to cover it briefly. We're going to cover it briefly. Let's. Here's an image displaying how the kidneys regulate your blood pressure. Like, long story short, a series of organs are releasing hormones that combine to control your blood pressure. I think we can answer the question quick. This one looks like a simple explanation. Basically, your kidneys detect low blood pressure. They will release renin. Renin combines with a hormone released from your liver. They combine to make the first version of that thing. Then a hormone comes out of your lungs to make the second version of that thing. That is called angiotensin, let's call it ACE, right? It's ACE. It makes the angiotensin into angiotensin 2, which then goes into your heart cells to make them increase, your vasoconstriction so that your blood pressure goes up. But when you talk about all the lulls, blood pressure stuff, it lowers cardiac function, metoprolol, propranolol, these kind of things. ACE inhibitors don't affect your heart in that way. They interrupt this hormone, which doesn't allow this one to become that and affect your system.
And where does the baroreceptors in the carotid and aortic arch come in controlling blood pressure?
Brother, I'm glad you asked. Now, let's talk about the first fastest way your body reacts to blood pressure issues. When the baroreceptors, which are what? Changes in pressure, right? So as pressure increases, as pressure decreases, and those sensors aren't found in your fingertips, they aren't found in your hair, they are found specifically in your carotid bodies, in your aortic arch. And when they detect that your blood pressure is too high, they are going to activate your autonomic nervous system. It means they're going to release hormones and signals to increase your sympathetic response and decrease your what?
Parasympathetic.
Parasympathetic. So activation of these baroreceptors is going to cause your heart rate to go up. Why? Well, because your sympathetic nervous system does that. It's going to increase your contractility. If heart rate is chronotropic, what is contractility? Inotropic, to squeeze harder, like pumping iron, right? It's also going to cause vasoconstriction to raise your blood pressure. This is the fast version, right? It happens quick. You with me so far? Are you sure? Such water. This is deep water. I want to skip past you. How you doing, Haley? You all right? Okay. The second way our blood pressure is regulated is through the RAS system. Now, I'm not about to teach you the RAS system. What I'm about to tell you is essentially that the kidneys increase our blood pressure. And I'm going to tell you how they do that pretty simply. If I get a quart low because I'm losing blood, I'm going to get an autonomic and sympathetic response, right? That makes sense. What's one of the earliest signs of hypovolemia? Tachycardia. Your heart rate's kicking up. Now we have a suspicion as to why your heart rate is up. Alex, can you tell me in a fancy way, if a guy is dehydrated and his heart rate went up, what is happening to do that?
The baroreceptors.
Baroreceptors are activating? Wow. Wow, wow, wow. Love it. Now, that's the kind of sprint effect to your blood pressure. But of course, you might need a longer lasting, more endurance effect, and that's the RAS system. Okay? Basically, what I mean by this is that your blood pressure is going to be determined to be low. Your baroreceptors and carotid arch, in the carotid archway and the coronary arteries are going to cause your autonomic nervous system, but so too will your kidneys detect that change, and they will start holding on to sodium. If your blood pressure is low, they will stop excreting the solute sodium. Why would holding on and retaining to more solute cause a blood pressure to increase? Because, yes, what? Yes, yes, yes. High five each other. Yeah.
I was saying the shape fluids because it follows the solutes.
That's exactly right, because it's following the solutes. Put pretty simply, when somebody is hyperglycemic, we often say, oh, well, their body's trying to get rid of the sugar. I don't know that it's trying to so much as saying that every time I drop this box, it's trying to get to the floor. I'm like, no, that's just the physics of gravity, right? If your kidneys detect low blood pressure, one of the things they will do is hold onto sodium and stop excreting it, which is going to mean that you are going to reabsorb more water. So the RAS system in a nutshell is your kidneys hold on to sodium to increase your blood pressure. Now the other part of this, I guess, is that I think that's all I want to say on that. The RAS system does more. It does all kinds of things like vasoconstriction. There's a conversation about aldosterone release. I used to have this image where I talked about aldosterone as like he's a bouncer at a bar and he won't let the sodium come in, and it was just like, it was this whole thing. It's just so fun to say aldosterone. But in any event, what I need you to remember is that if your blood pressure drops, it's not just an EMT. We said, oh, what happens? Well, I go into compensation. Okay, that's great. Now I want you to be able to say why that compensation is occurring. And the answer is well, because my baroreceptors and my carotid archways and aorta are reacting, but so too are my kidneys retaining what? Sodium. Careful not to say salt. I do it all the time. I do it all the time. I had a picture on this morning of a salt shaker. And I was like, sodium. Now, what's important to know, and part of the reason why I gave credit to a question a few quizzes ago, is I asked a question that said something to the effect of, as baroreceptors are stimulated, what would you consider? And it was like, basically my understanding of the baroreceptor innervation was kind of like this, that like our default is 0. And then if my blood pressure is low, I'm going to cause adrenergic response that's going to increase my blood pressure, increase vasoconstriction. And so when my blood pressure falls, it's less that something is making it fall and more just I'm just having less adrenergic stimulation from my baroreceptors. And that was half true. Basically, we don't just have the sympathetic and the autonomic nervous system. What else is there? Parasympathetic. It's phrased like a trick, but it's really not. What that means is that when I want my when my baroreceptors are stimulated, they will release 2 hormones, basically. One is going to increase my sympathetic response. What's the other hormone going to do to the parasympathetic response?
Increase it, inhibit it.
Stop releasing it.
It's going to kick in the parasympathetic nerve.
Okay. If the adrenergic response is the gas pedal and I want to go faster, I want a higher height rate, do I push harder on the gas pedal or take my foot off? I press harder. So I want to agonize or activate my sympathetic nervous system. But if I don't want the brake to be pressed enough, do I push harder on the brake or take my foot off the brake? You take it off, which means that second hormone is discouraging the parasympathetic response, because if I encourage the parasympathetic response, it's going the other way. Whew. So all I mean to say is that these baroreceptors are working on our sympathetic and parasympathetic, but in opposite directions, if you will. My heart rate gets low, my baroreceptors determine that something is wrong, so does my kidneys, and it's going to instigate a adrenergic response and discourage my parasympathetic response. If I notice my blood pressure is too high, what are my baroreceptors going to do to the parasympathetic nervous system? They're going to encourage the parasympathetic because it's wanting to push harder on the brake. What if my blood pressure is too high? Are my baroreceptors going to do to the sympathetic nervous system? Very good. Okay. Here's what I want to do real quick. We're going to pair off. One of you is a high blood pressure situation. One of you is a low blood pressure situation. And I want you to talk about what is happening with the sympathetic and parasympathetic nervous system, encouraging, discouraging, regards to the baroreceptors, right? Let's see. Aiden, you're over here. And then that's it. Turn to your partner. Pow. Your high blood pressure. Now tell her what's going to happen when your baroreceptors detect that.
Low blood pressure. So I'm going to agonize.
Okay, yeah. It would increases the heart rate.
You're welcome. I wasn't listening. I'm tough, dude. It's hard when you're so tough.
From the cells, right?
I'm going home.
You going?
Are dysrhythmias not an issue when you're...
All right, Sam, which one were you?
Whichever one you want. I was low, but
Okay.
she had a good answer, so I'll take her answer first.
Okay, what's your question?
So I hear people with high blood pressure say they have a low sodium diet.
I hear people.
Like people who are
Yeah.
diagnosed with hypertension, they'll say, "Oh, you got a low sodium
Keep
diet."
going. Keep going.
But wouldn't you, if your body is excreting the sodium, you want to keep giving it the sodium, or do you
Okay.
think it would just cause that?
So
Causing
I have high blood pressure, which means if I add sodium to my system, I'm adding solute, which means water is going to. You feel that? Dun, 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 dun. Yeah, cool. That's cool. That's cool. Yeah. So they're low sodium diet in part because low salt diet because half of that is sodium. And the sodium, if it goes high, is going to cause them to retain water, which is going to do what to their blood pressure? Yeah, buddy. Whole snap. Okay, so you were low blood pressure. What's going to happen when your baroreceptor detects that in regards to your parasympathetic nervous system?
It's going to activate parasympathetic.
Uh-oh.
Vasoconstriction and higher heart rate.
You are very close, but exactly opposite.
He said it right when he explained
Yeah.
it. He said it right when he explained it.
Okay. Right, because if I give you epi, which is an adrenergic on the sympathetic nervous system, we're going to expect high heart rate, vasoconstriction. So, okay, so you're low blood pressure. Your body is like, whoa, I can detect this through the baroreceptor. What's it going to say to, hey, parasympathetic nervous system, I need you to chill, dude. I need you to chill. Because if you keep doing that, you're going to cause vasodilation and bradycardia, and my heart rate's going to go down. So, anybody else low blood pressure? So, Alanis, if your baroreceptors detect a low blood pressure, what's it going to do to your sympathetic nervous system? Oh, no.
to do stuff.
It's going to not inhibit, it's going to encourage it. Yeah. That's okay, very close, just completely wrong. That's all. Very close. When you can flip a coin, it's only one of two sides. It's not a hard correction to get to the other one, right? Very good. Lauren, or Sabina, which one was high blood pressure? You were. What is it if your baroreceptors detect high blood? I like that confidence, by the way. It's me, dog. What do you got? High blood pressure. What is it going to do to your sympathetic nervous system?
It's gonna keep it
Yeah, decrease the effects because increasing it. Very great. Anybody over here? Kendall, Destiny? High blood pressure? Your high blood pressure. Oh God, deer in headlights, look.
Oh, I thought it was low.
That's okay. Your high blood pressure now because she threw you under the bus. She just looks like the type that would be high blood pressure. That's what's, okay. Your high blood pressure, your baroreceptors are detecting it. What's it going to do to the parasympathetic nervous system?
I'm high.
Your blood pressure is high. Yeah, because it wants your blood pressure to go down. So it's having, hey, chill, chill on the sympathetic nervous system, but my rest and digest needs to ramp up. Okay. We getting there? Good job. So, put pretty simply, baroreceptors regulate pressure minute to minute, right? This is the fast response, and the RAS system involving the kidneys and a whole mess of other organs and hormones is how we do the long game.
Since the kidneys deal with sodium, are there any risks or involvement of dysrhythmias, or is it more like kidney dysfunction would be?
When we get dispatched to end-stage renal, I am always thinking like, well, what electrolyte soup am I about to walk into? If your kidneys are failing, you do not appropriately process like any electrolyte, which leaves you very prone to all kinds of issues, not the least of which is dysrhythmias.
So it's more kidney dysfunction rather than like
Yes.
the management.
Yeah, yep.
Okay.
And potassium is going to kill you with a dysrhythmia before the sodium does. Not that sodium can't cause a problem, but it's the potassium levels. Like, they are watching their diet for phosphorus and potassium like crazy because those are the ones going to cause major issues.
Okay.
So
But they all can.
I was looking over the slides for the quiz today.
Yeah.
You kind of went over the sympathetic and parasympathetic with like the slide with the dog and the chain.
Yeah.
I was under like, does the parasympathetic like control the sympathetic in a way that like
Pulls against it. You're like, but the chain is directly on the dog. It looks like it's arguably two hands pulling in either direction is perhaps better. But that picture will make more sense when you get, are you going to medic? It'll make, I think, more sense when you get access to things like atropine and adenosine, and that picture will be like, oh, yeah. But no, it doesn't directly affect it.
So it's more of like a tug of war?
Competitive. Yeah, good distinction. Now, with solid organs, we're going to start talking with the pancreas, or not talk, I guess, or rather not start, we're finishing with the pancreas. The pancreas is an interesting organ because it's both digestive and hormonal. So it's both an endocrine and an exocrine organ, not that I necessarily need you to remember that. But it does release bile that aids in, or it does release enzymes, I should say, that aids in digestion. But it also releases our sugar managing hormones like insulin and glucagon, which means if you've got a pancreas issue, you've got major problems, right? You got promoted from lieutenant. One of the interesting functions of the pancreas is that it releases bicarb in part to neutralize your stomach acid. You've got a bunch of hydrochloric acid in there that is meant to break stuff down into what they call chyme, which I think is such a pretty word for such a gross thing. And that stomach acid would go into your intestines if not for your pancreas neutralizing it. The point, I guess, is that I think sometimes we're like, oh, pancreatitis, that's not great. I'm like, no, it's super bad.
Does the same thing happen when you get like pancreatic cancer?
Yeah. Pancreatic cancer is one of the most,
It's the fastest way to die, dude.
Yeah, isn't it like the worst type of cancer?
yeah, I don't know how to phrase it completely correct, but it's some version of more people die of pancreatic cancer than many other ones.
Yeah, it's basically that's what my nana died from, and that's why I was worried because I was putting together like what she was.
Digestive, sugar, which is metabolism, which is, dude, but the issue isn't necessarily that like somehow that pancreatic cancer is like super special. It's that it's almost completely asymptomatic until it kills you.
Yeah.
I had a buddy that was a nurse. The story is she got kicked in the stomach by a psych patient, and she was pissed off, and perhaps rightfully so. The next day I said, hey, how you doing? She said, I still hurt. I was like, I mean, torn muscles, I guess. Did you get checked out? Nah, it's just a kick. Next day comes, man, I'm still hurting. I'm like, you thought about going to see a doctor? I don't see her for like 2 weeks after that. She had pancreatic cancer. Because the dude kicked her, she went in to go see a doctor. They scanned it. They found pancreatic cancer, and she lived. But otherwise, she would have had it wasn't that she got kicked in her hurting pancreas. It was just a random chance, if you will, that she got kicked and got investigated. But that's how they found it, and now she's alive. But so I don't know about like, if you get pancreatic cancer, that's like, you're done for. I'm like, no, it's usually by the time they figure it out, it's way too late. Oh, I don't know. Eesh. Cancer sucks. Yeah, summary is, don't do it. Yeah, man, do not recommend. Yeah, I mean, my grandma got skin cancer, and she had a syncopal episode they thought was a stroke. We're in Georgia, she's in Michigan. I was like, oh no. I was like, we'll see what the neurologist says. I don't know whether I need to necessarily go up like right now. They were like, oh, your cancer is metastasized into your brain. That's why you had a syncopal episode. So we got on the horn with the family, and I was like, hey guys, go to Michigan and see grandma. And their response to me was, the doctor said she might have a few years to live. And I said, she has cancer in her brain. Like, that is a fast timeline. And they're like, I don't know, Stephen, he's a doctor. I'm like, yeah, what do I know? I've only been watching people die for the last 12 years in my career. What do I know? I went up to see her. We caught a plane and flew up that weekend, and she died the next weekend. And I rubbed it in all their faces at the funeral. No, I didn't, but I was like, oh, stomping around the funeral, high-fiving my grandma. She would have loved that, by the way. She was a homie. She was a real one. I miss my grandma big time. Sometimes I forget, she's been dead for years. Sometimes I'll see a movie and then think, I gotta call her. She'd have loved that. I'm like, she's been gone for a long time. People always say they marry their mothers and their fathers. I married my grandma for sure. My wife is the same old Polish hard nail. Anyway. So sequential digestion, essentially. Basically, we go from the mouth to the stomach. This is more of a mixing and breakdown. The stomach is kind of chunking it down. that goes through the process in the small intestine. And the small intestine is at the duodenum. I don't think it exists on this slide. I used to ask a question, just like I would the upper airway, what separates the upper and lower airway? Yeah, the duodenum or the duodenum, essentially, it is the separate. It is the beginning of the small intestine.
Oh, okay.
So, I don't know. I'm not sure. I don't know. I don't remember if I have a test question on it. But it would be reasonable to think you should be able to separate, because we talk about it in hemorrhages, upper GI, lower GI. Well, where's the line? At the duodenum. So, just past the stomach. Now, at the duodenum, essentially, that's where our pancreas and our gallbladder are starting to affect the digestive process. In fact, by definition, digestion isn't happening until then.
Where does the small and large intestine split?
No idea.
Okay.
Somewhere in the tummy. Now, one thing that I'm sure of is that we need to make distinction between intra or inside the peritoneal cavity organs, but more to the point, those that are outside of it, or specifically behind it, the retroperitoneal cavity. That's a big one. And part of it is the presentation of bleeding.
Did you already write it?
She's here, we can continue. All right, listen up, we gotta go. So, intraperitoneal organs, right? I've got them kind of highlighted here. Does anybody see, based on the coloration, what the distinction is between these? There you go. Hollow and solid is what I'm trying to do. I try to kind of maintain that for the rest of the presentation, but you'll see that doesn't always hold true. But my hope is to kind of instigate that hollow and solid organs. It's a big part of it. Now, like I said, what's real important here is being able to distinguish the retroperitoneal organs, right? That involve organs outside of your peritoneal cavity. Now, in case I don't mention it later, when we talk about Gray-Turner and Cullen's sign, okay, those are indications of retroperitoneal hemorrhaging, which means if I see Cullen's or I see Gray turn to the side, right, I am suspecting a vampire. No, I'm suspecting retroperitoneal hemorrhage. Now, it doesn't mean you don't have intraperitoneal hemorrhaging. Are you surprised to learn that if you have damage that lacerated your spleen, which is what, intra or retroperitoneal? Intra, that it might also rupture your peritoneal lining, that then causes the intraperitoneal hemorrhaging to leak out. So we have to be careful not to say, oh, well, I see Cullen's sign and I see Gray-Turner's, therefore this is only retroperitoneal. No, it could be both. Because if your peritoneal lining is ruptured and it's bleeding in there, it could come out.
So Cullen's can be both.
It is 100% a sign of retroperitoneal hemorrhage. The question is that only where you're bleeding? What you shouldn't say is that, oh, I see bruising around the umbilicus or I see bruising in the flank, therefore it's none of the intraperitoneal organs. No, we just know that it's bleeding on the outside. We're not sure whether or not it started from the inside. It's one of the most common confusions about that stuff. Now, our retroperitoneal organs largely consist of our aorta and inferior vena cava. In fact, on some thinner people, you can press hard enough on their stomach, you can feel their heartbeat because of their aorta. It's not that difficult to do. Admittedly, it's getting a little harder on me as wintertime comes and I put on mass, but you gotta bulk up. In any event, the pancreas is also retroperitoneal, asterisks. The kidneys, and therefore their little winter caps, the adrenal glands that sit just on top of them, those are also retroperitoneal. And so too are big portions of our ureters. Which means, if I asked a question that said, your patient presents with left flank bruising, which is called what?
Gray-Turner's.
Gray-Turner's, which is a sign of what?
Retroperitoneal.
Retroperitoneal hemorrhaging. Which of the following should you most likely suspect is causing that? Liver, spleen, kidney, stomach. kidney, because it's retroperitoneal and we have a sign. Now, could it be any of those? Yes, it could. Lauren, do you have any idea how a spleen bleed could cause a retroperitoneal hemorrhage? Okay, appreciate that answer. Right? Is your spleen inside the peritoneum or outside? It's inside, because these are the only ones outside. Shannon, how could an organ that is inside the peritoneal cavity cause hemorrhaging outside the peritoneal cavity? If your peritoneal cavity lining is ruptured, then it will bleed from the inside of that to the outside of that.
I have a question.
Yes.
So then can we do like one of the signs on them and figure out?
Like obturators and all that stuff? You can. We're looking largely for peritonitis at that point, and less perhaps of a hemorrhaging issue, but you could.
On the last slide, the asterisk next to the pancreas, is that what you mean? Like, if that one bleeds, it goes through?
How astute. Let's kind of get to it. See,
Couldn't that be true for any of the stuff in the...
it could be true for any of them. It is particularly true for the pancreas.
Okay, that's why I was thinking. I was trying to make the distinction. 'cause, like,
Oh,
in my
here's
mind-
why.
Okay.
The pancreas extends through the peritoneal cavity. The majority of it is inside, but the tail of it is outside of the peritoneal cavity, which means when you get pancreatitis, you can get Gray-Turner sign and never have any hemorrhaging. No, I don't mean to say that. Like, you would say, well, isn't it true that the pancreas is largely an intraperitoneal organ? I'm like, yeah, it is, but it is also partly outside the peritoneum, which means if you get pancreatitis, you can get Gray-Turner sign and Cullen's. Yeah. One little appendix, 30-minute discussion. Or asterisks, I should say. Now, your urinary tract, it largely includes your kidneys, your ureters, and your bladder, right? That's kind of the function there. And you can get all kinds of dysfunction down all of that. And then suddenly I cut to a completely different slide. Basically, what I'm trying to accomplish with this is that our retroperitoneal organs are what's going to get us to, this is my way of saying, like, hey, Gray-Turner's and Cullen's signs should make us stronger suspicion of retroperitoneal organs, right? Which means, for example, is my aorta retroperitoneal?
Yes.
It is. It's going behind the, let's call it, I don't want to call it stomach lining because that's a completely different thing, but it's going behind the peritoneal cavity, which means that if I have some suspicion that I'm having an aortic aneurysm dissection or rupture issue and I have Gray-Turner's sign, now I'm deadly sure of it. You see what I'm saying? Because it isn't bleeding inside of the peritoneal cavity. Now this is Cullen's sign, and I remember it because I just make a C around my umbilicus. Right? That's Cullen's sign, and it may indicate an intraperitoneal bleed, but it's specifically indicative of a retroperitoneal bleed. Likewise, our Gray-Turner's, or turn to the side, this is our flank bruising and hemorrhaging. Yes, it is a sign of retroperitoneal hemorrhage, but it could indicate intraperitoneal with a ruptured peritoneal cavity, right? It can present all kinds of ways. Be careful. Part of the reason I include this picture is because you're like, wait a second, that's not in the shape of a C. Like, well, the C is just a memory device. It's not that it's actually in the shape of a C. So you approach a patient who's complaining of left flank pain, and I immediately start thinking which organ? Kidney for sure. I start asking them about their urinary situation. They're like, oh, it's fine. No burning on peeing, nothing like that. I say, well, okay, sweetie, well, let me take a look. And I lift it up and I see that. What do I now think? Not urinary, blood for sure. All right, let's break down our types of pain. Visceral pain. I put a vampire here because it starts with a V. The source of your visceral pain is your organs because they are deep in your body, which makes that pain vague.
What is vague?
Vague, crampy, aching, diffuse, dull. Like if you said, One of the ways I get patients to distinguish vague from sharp pain or somatic pain is they're like, I don't know what these words mean. And I say, okay, sweetie, does it feel more like my finger pressing on you or a little more like my whole hand? And they're like, oh, whole hand. I'm like, okay, I'm going to call that vague, right? It's more of a diffuse situation. You could argue that that experience I just said was localized and therefore possibly somatic, but vague means it's hard to tell exactly where it's from. And it makes sense to me because if you consider you've got a, part of your gallbladder is having an issue, there's not really any sensory nerves on the inside of your body to say, hey, here's where it is. You're just like, I don't know, it kind of hurts in my back a little and on my front, I don't really know. That's vague and visceral pain. So vague visceral pain usually indicates an organ dysfunction. It's poorly localized. It's difficult to pinpoint. And this knowledge of this, I think, will help you differentiate stages of organ dysfunction, like in appendicitis. If your patient complains of pain in the lower right quadrant, just everywhere, I might think it's appendix because it's deep in there and vague. If it's just somewhere in this area. McBurney's point is highly specific. That is not visceral pain. It's right on the money, right? The reason why we can say, well, McBurney's point is a far greater issue is because as our pain extends from the organ and starts causing peritoneal inflammation, well, that's where all my sensories neurons are. I can feel this. I could tell if you just, put an ice cube somewhere on my stomach, and depending on our relationship, you're welcome to, but I could tell you exactly where that ice cube was because I have sensory nerves that will do that, right? But if my appendix is starting to get inflamed, I don't have sensory nerves in there, and it just feels like this generic, vague, visceral experience, which means if you suspect appendicitis and they have a positive McBurney's point, what have you discovered about their condition? It's in the late stages. It is now not just an inflamed organ, it is starting to inflame the six-pack of abs. No, peritoneal lining. And peritonitis is a what? A surgical emergency. What I'm saying to you is that if you have a hard time describing your pain, it might be deep in you where the sensory nerves aren't. And the more specific you are to be about it, the more I'm thinking that that rupture or that sepsis or that inflammation has now progressed into inflaming your entire cavity. Because if you're highly specific about it, we're now involving sensory nerves. I think that's so cool. So somatic pain is largely resulting from our parietal. Parietal means wall. If you're able to pinpoint exactly where you're hurting, we're starting to think that it's not just organ involvement, it might also be the peritoneal lining, which is peritonitis, or at least indicative of. We describe somatic as largely sharp, and it's often constant. Ow, 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 ow. Right? One finger instead of a wide hand, though arguably that could be described as somatic as well. It's easy to pinpoint. Pam, why is appendicitis that is now caused peritonitis, why is it easier to pinpoint once it becomes peritonitis? Yeah, any idea why suddenly it's able to communicate to me more specifically than when it was just the organ? Okay, well, it was the right answer for sure up to that point, Alanis. Just because we have sensory nerves near the lining. We don't have them deep on the inside. Some of us have no sensory, even in our heart, because they're just cold, dead animals. Now, colicky pain is a very specific pain. Colicky pain largely just means visceral with rhythm. It means I've got this vague pain and it comes and goes. If you just said, I don't know, I'm just kind of hurting in this area. If I touch it, does it hurt more? Yeah. Well, is it like right here? I don't know, man, it's all over. Cool, visceral. Well, with your pain, does it come and go or is it constant? I don't know, sometimes it's there, sometimes it's gone. Great, that's not just visceral, that's colic. It comes and goes. Now, a lot of times you can make a strong association between this vague, intermittent, muscle spasmy pain with stones in you, or at least obstruction. If you said, Mr. Fearon, my patient was describing colicky pain, what do you think it was? I said, how is his gallstone? How is his kidneys? And how is his bowels? Because often colic describes a mechanical problem. Something in you is moving or not moving in some ways. Now, referred pain is not radiating pain. Radiating pain has a trail to it, right? Meaning, if you ever seen people burn wood with electricity? Essentially, it just creates this spiraling. Think about a sand castle and you pour water on it and it creates this notable trail. You could tell, despite it having now a pool of water at the bottom, where it started because it has a trail. That's radiating pain. I hurt here in my shoulder, ouch in my bicep, oof in my whatever this is that's not a femur, forearm, there we are, and all the way into my hand. That's a radiating experience. Now, when I hurt somewhere and also somewhere else, not only do we talk about that as being referred pain, what we're talking about is an organ that does not have specific sensory nerves that is communicating essentially through a different pathway. The big thing you need to remember is that right shoulder pain is often indicative of gallbladder issues and sometimes liver. Right shoulder, gallbladder, and liver. Where this becomes the most difficult is not in an abdominal test. Where it becomes most difficult is in a final, where it encompasses everything. And suddenly your patient is dyspneic, chest pain, and abdominal pain that radiates to the blah, and you're like, okay, is this heart attack that's presenting weird or a specific organ, right? One of the easiest ways through is right-sided organs, right-sided shoulder pain. With me so far? On the other side, spleen is on the left side, right? That's where the glass mnemonic ends, on the left side of the patient, and it can radiate to your left shoulder, right? Do a quick pair and share here. One of you has left shoulder, one of you has right shoulder. Tell them what organ you think the problem is. Tell her. You got right shoulder pain, she has left shoulder. Talk about the organs.
So you
Murphy sign. Is that, was it inhalation or expert? Inhalation.
Yep. Every picture I looked up about it showed people laying on the ground. I thought you had to do it standing. I switched the slide so it wasn't so descriptive, it got more descriptive. F. Did you do it? I believe you. I believe everything you say. All right, now, what this is called essentially, this specific left upper quadrant, right? ULQ, upper left quadrant. Okay, that's the nomenclature of our quadrants for our organs. RLQ, these kind of things. Well, wouldn't be RLQ. LLQ. LLQJ. This is called Kehr's sign. Now, if you asked me, my patient has left shoulder pain from an abdominal issue, what is it? I'd say it's probably a spleen problem and it's probably Kehr's sign specifically. Great. I'm a little confused about it specifically because where the line blurs is that what we're kind of looking at here is peritoneal reaction. Sometimes a diaphragm issue will also cause Kehr's sign because they're in the same area. It's all this peritoneal lining issue. So just be conscientious of that. Now let's talk about a whole bunch of other things.
So is the shoulder pain on palpation or is it constant?
Constant.
Okay.
Guys like, oh man, I'm just hurting all over. Like really where? Can you be more specific? I don't know, I guess my stomach. Is that the only place? Also up here. I'm like, whoa, you've been in a car wreck or a fall or a cartwheel didn't work out like you thought it should? Because the only thing I know that would cause that is a spleen problem. They're like, no, I'm fine. And I'm like, okay, let's check your temperature and then look for not a hemorrhage issue, but a inflammation issue because that is so highly specific. Sir, you ever had shoulder pain before? Nah, not like this. I'm like, okay, we got a unique association here. But to answer your question, no, it'll just be happening all on its own. Now with medical belly, we're going to talk about a couple of different things. Obviously, I'm doing this little tongue-in-cheek because I'm not talking about your stomach necessarily, but rather your abdominal cavity and the organs therein. Now with appendicitis, we have a visceral pain. Destiny, what does that mean, visceral pain? That would be referred. Alex, referred pain? Or sorry, vague pain?
Visceral is like diffuse.
F. Good job. You speak Mr. Fearon. You're doing fine. Okay, very good. N and V, what's that? Nausea, vomiting, right? Now, again, I'm doing my best here not to list a infinity amount of signs that all of these things can include. We're looking for key stuff that gets us thinking one or the other, right? Now, with later finding, we might experience... Huh? Dude, everything. Somebody tell me, in fact, well, I think we can get there another direction. Somatic pain, Landon, somatic pain? Sharp, sure. Sebastian, why is it that an early sign of appendicitis might be visceral and a later sign might be somatic?
Because the swelling will, like, it'll increase over time, so the sensory nerves will end up getting touched.
The idea being that if it swells enough, you're getting closer to, sure. I don't know. My assumption has always kind of been that my appendix is becoming engorged and problematic, and now it's starting to leak out into and affecting the but I don't know whether it's the physical structure getting closer. I have a suspicion that it's more just involving the peritoneal cavity now. But in either case, we got to the same place. So, which is when we're going to start to see McBurney's point, right? It's also why we're starting to have fever and tachycardia. Somebody tell me essentially, let's see, I don't know, Sam? I can't remember who I haven't called in today. Can you tell me why a later finding of appendicitis might be fever and tachycardia? Like, why now? Why not immediately?
Would it be just a buildup of the inflammation cause the body to react?
There you are. We're starting to become systemic, right? Like, it's not just an organ having a problem. It's now involving the peritoneal lining, and our whole body is starting to react. And if my guy has a positive McBurney sign and says, look, I'll just go see my doctor tomorrow, Almeida, can you convince me? I think I have appendicitis. I've got fever, tachycardia, rebound tenderness, and somatic pain from McBurney's point. And he says, look, I don't have insurance. I'll just go to the urgent care tomorrow for this. Can you convince me why I need to go now?
I would say something like hospitals don't care about insurance. They just want to make sure, okay, the appendicitis is likely leaking, going to cause infection soon. So
I am very impressed. In summary, because, brother, you won the second stage now, we are talking about peritonitis. We're talking about an elevation of your problem. Well done, right? This isn't wait and go to the urgent care stuff, brother. You got a bigger issue. Your body's being affected. Now, there's a whole host of different things that we want to talk about here. Know this, I don't remember where I saw it. It might even be my own test. But, yeah, well, part of it, there's some anatomy, I think, that you just become familiar with. You forget isn't normal nomenclature. And one of those is our iliac spine, right? So let me help you through this. The McBurney point is 2/3 the distance from the navel or the umbilicus, right? To what's called your right anterior superior iliac spine, or much easier to remember, front of your hip bone. Right? So here's my hip bone. I'm not talking about up here, I'm talking about the front of it, right? Superior and anterior. So it's up here. So that means essentially 2/3 the distance from here to the front of my hip, or where my belt sits. Come on, I'm a gangster. So, got it? I've seen portions of that on the registry a bunch of times. Now, there's a whole host of other things. I usually make them wrong answers on a test because I care most about McBurney's, right? But by definition, rebound tenderness is technically Bloomberg's sign. Rav Singh's is paradoxical. What's paradoxical mean? Opposite, which means I'm experiencing right-sided pain because I'm pressing on the why. John, why would the right, if I have appendicitis, why would it hurt if I pressed on the left side?
Swelling of everything.
Peritonitis. if I'm experiencing Rovsing's paradoxical or press on the left and now my right hurts, it's not just a right-sided problem. I have a peritoneal lining issue, and peritonitis is a what emergency?
Surgical.
Surgical. He's like, oh, my stomach really hurts. No, it doesn't hurt, buddy. You got a leaking organ. Whether it's ruptured or septic, you got to go. Yeah.
So with the Rovsings, are you pressing on the origin of the issue and then it's resonating because of the lining issue? Or
Other way around.
So you would press
Like-
on the lining and then this is like the appendix, you would feel it
Yeah, it's like
the other way?
my appendix is over here.
Yeah.
I press over there, and it's moving the one thing that connects those two, which is the peritoneal lining. In a little way, in a dramatic and ridiculous way, it'd be like having my right thumb broken, and I squeezed the left one, and it was like, ouch! I'm like, okay, well, you'd have to squeeze the left thumb pretty hard to move the whole body, but that's the similar principle. Sebastian?
So does when this is paradoxical, does the side with the injury on it, like, also hurt on some patient?
Nope.
No.
Yeah.
Like, not at all.
Minimally, if anything.
Okay.
I push over here, and he's like, ouch! I'm like, that's weird. Well, it's not weird considering this whole organ is connected and that the peritonitis.
That's why I would think it would still hurt on the same side.
I mean, on a long enough timeline, sure, you probably press on that guy's back and it would hurt. But initial signs and for most testing purposes, no. Now, there's leg muscle pains that can involve it. You've got the obturator sign because it's the obturator muscle that it involves, and you have the psoas sign because it involves the psoas muscle, but they're both leg muscles. Rose, why would movement of a leg muscle cause pain in the abdominal cavity? Like, why do we have two different leg signs that are indicative of appendicitis? Henry?
Is it because it's like applying pressure?
Moving the peritoneal cavity. So what we have here is a huge amount of signs, all indicating ultimately what? Okay, that's a good answer. Peritonitis. The question that I want to ask now is what? Why then
What would make it an
appendicitis? How these, if you Google like signs of appendicitis, all of these will come up. But really, these are more signs of what other organs can cause peritonitis? Any. So why are these all indicative of this? Because history. Because when we were discovering appendicitis, we found all of these things were strongly indicative of that, because appendicitis' worst outcome is peritonitis. So yes, they're signs of appendicitis, but they can also be, they're most specifically just signs of peritonitis, which, so if I got a patient who's complaining of left upper quadrant abdominal pain, but has obturator sign, what have I just learned? Not that he suddenly also has appendicitis. You see what I'm saying? I think that's so cool.
Peritonitis is just inflammation inside.
It is the cavity that's holding all of your intraperitoneal organs. Your stomach, your liver, your gallbladder, all those things are all encased in a peritoneal lining. Your kidneys sit behind it, your aorta sit behind it. It's just the abdominal cavity.
So it becomes peritonitis at any point when any of those are affected, basically?
It's like their second stage. If you've got a poisonous thing in you, like an appendix that is getting worse and worse, it will flow out into the surrounding tissues like your lining and start to come with a different problem. Rose, do you remember your question?
I was gonna say, what happened to the one where you strike the heel?
Merkel's, just a long list of stuff we don't need to, or Markle, I think technically, where you just drop the heel.
Or like the lip,
Murphy's sign, which is gallbladder, which is why you won't see it here.
no,
Yes.
no, not, that's not what I'm talking about. Where you lift the head.
Oh, I don't know. I don't think you're going to get obturator psoas and stuff like that. And on my test, they're usually the wrong answer. But what I definitely need is for you to understand conceptually that this stuff is showing that it's involving movement of the peritoneal lining. And that's why we're having an issue. And then also know that that is historically associated with appendicitis because it's the #1 culprit of peritonitis in many ways, right? So, but there are all those signs. Dude, I'm pretty sure none of you for the entirety and history of my career will get a question on Markles and these and psoas. But if you have the reason why I expose you to it, so you can be like sitting at the registry going, I remember psoas. That was something about appendicitis and stuff. You know what I mean? So I'm just trying to kind of get you close. Now, these are signs specifically of appendicitis, but they can be strongly indicative of late signs of appendicitis, but more to the point, peritonitis, which is a visceral pain. No, somatic pain. That's wrong. We would call all of this our pre-rupture phase, that we're starting to have this major inflammatory process. Now, appendix rupture or disruption, which is largely synonymous, is a progression. That's where something has happened in our appendix. Usually it's an obstruction, stuff getting clogged up in there, which is going to lead to a dysfunction of the organ, meaning inflammation. Enough inflammation and fluid and swelling is going to cause a perforation. And then, of course, it can get so bad that it'll cause sepsis. I don't know. Right? And then septic shock, and then MODS, and then death, right? That any organ that is dysfunctional can kill you. Now, if you get dysfunction of a kidney, will you die from that?
Do they from the effects?
You could. You could say, well, I still have the other kidney. I'm like, no. If you have an organ that is poisoning you, it doesn't matter if you have a second one that can maintain the function, that organ's got to go. It'll kill you. It's like having an irradiated pellet inside of you. Now, a key finding of appendix rupture, which is the most lethal stage, is the sudden relief that gradually develops pain again. This is I called because I just felt so much pain. And by the time the EMS gets there, they're like, actually, I don't feel much pain. I'm just dizzy. Are they getting better or worse? You see what I'm saying? Well, I'm glad the tension is released. Unfortunately for you, that means you're either hemorrhaging or leaking digestive contents all inside your peritoneal cavity, right? So we're looking now for sure rigidity and shock, but again, this rigidity has less to do with the appendicitis specifically and more to do with us filling up in our peritoneal cavity. Now, cholecystitis is gallbladder, right? I see it more often referred to cholecystitis than I do gallbladder inflammation. So make sure you know that word. I don't super care that you know that nephro is referring to kidney. I do care a bit that you know that HEP essentially is referring to the liver, but you definitely need to know that cholecystitis is gallbladder issues. And more to the point, almost always gallstones. That if your patient has inflammation of the gallbladder, it is very possibly and very probably because they have gallstones. That's causing an obstruction. Why does it present with right upper quadrant pain, cholecystitis? Because that's where it do be at. It causes right shoulder and back pain. It's on that side. This is the reference to Murphy's. This is the Murphy sign. This is us grabbing underneath their ribs. You hate the sensation? Is that where your shaked head is?
So, like, I couldn't imagine like doing it.
Yeah, I never have in my career. Guys like, oh, I hurt right here. I'm like, okay, let me be real sure about this. Tell the doctor, don't worry about blood draws or scans at all. Positive Murphy sign, dude. Just get out that gallbladder. I'm like, no. No. All right. Again, the rupture will cause us to have sepsis, perforation, peritonitis. They're all going to follow the similar pathways, ultimately ending in your doom. And then here's a picture of that. Moving on. Murphy's sign is the pressing. It's literally putting pressure on your gallbladder. You inhale and slowly exhale, and that allows me to put pressure on your gallbladder. If it hurts, we call that Murphy's, strongly indicative of gallbladder sign. Now, what I think is on testing, sure, Murphy sign is a dead giveaway, but what I found in the field is association with eating. You see, your gallbladder aids in digestion by what they call emulsifying fats. What this means is that if somebody's got upper right quadrant abdominal pain And they say, and I said, well, does anything make it better or worse? Which is a question you've asked a million times and probably only valued once. Well, in situations like this, they could say, well, yeah, actually, you know what? Like if I said, you got right upper abdominal pain, that's not really where your stomach is. And they're like, well, that's weird because it usually hurts more after I eat. I'm like, okay, well, that's strongly indicative of your gallbladder issues, because your gallbladder is going to emit and excrete bile that helps turn these big globs of fat into small globs of fat. That's what it does. So if your gallbladder isn't working very well, when you eat fatty foods or generally just eat, you can get stomach pain afterwards because your gallbladder is not able to break down the fats. It also makes your poop float, which is fun and not good. So you can ask patients, right? We've been asking that since the beginning. How's your pee? How's your poop? Does it all float down here, right? Because if your poop is floating, then it might contain an excess of fat. And if that's associated with your right upper abdominal pain, starting to wonder if it's a gallbladder issue, because that's the organ that breaks that fat down. You thought Mr. Fearon was strange, always asking about poo-poo. Turns out I'm a genius. Pancreatitis. Pancreatitis is often caused by gallstone issues, but a very strong culprit is alcoholism. If you've got a patient with either right upper quadrant or left upper quadrant with jaundice, I'm starting to think that it's not just alcoholism, but it's some type of liver or pancreatic dysfunction. Pancreatitis is super dangerous, in part because it can cause retroperitoneal hemorrhaging, because again, that pancreas is halfway in and out of the basket. Now, I put signs and symptoms on here like nausea, vomiting, and fever, but it's nothing we haven't seen with every one of these organs causing an issue. Pancreatitis causes a dysfunction of that gastric issue. What other issues do you think these people have? You've got pancreatitis. What other problems do you have? Not just digestive.
Liver.
You might have liver.
What's the hormone system?
I have no idea. This is one of those things where I think when you get it, you're like, oh, duh. Huh? Diabetes. Right, because what does the pancreas do? Insulin and glucagon. Turns out when you got widespread inflammation of the organ, it doesn't do that so well, right? It sucks. Not recommended. We're going to talk about, we talked about some obstructive stuff. These are your stones and obstructions, these kind of things. Actually, that comes later. I guess we talked about inflammation. Now let's talk about some of these infections, gastroenteritis as well as peritonitis, which is really what we've been kind of centering a lot of this conversation around. Now, gastroenteritis is honestly not awesome, but not that big of a deal. Gastroenteritis is your inflamed stomach and intestines. A lot of times food poisoning. And a lot of times food poisoning is bacterial. You ate something that maybe you ought not have, but didn't know at the time. Now your stomach and intestines are reacting poorly. It can cause all kinds of cramping and tenderness. What might a cramping pain be described as? Somatic or visceral?
Visceral.
Sure, vague, cramping. If I said to you, I've got a patient complaining of a lot of pain since their last meal. They've got a fever and malaise, and they're experiencing vague cramping pain that comes and goes. How would I describe that pain? Colic. So that's when you have patients with gastroenteritis, you tell them, quit whinging, you're fine. No, we don't know that, and they definitely don't. I mean, we're all thinking worst case scenario until proven otherwise. Now, peritonitis is inflammation of the peritoneum, that lining of the abdominal cavity. Usually you're getting this not just from trauma, that's a hemorrhage issue. You're getting peritonitis from ruptured hollow organs or deeply septic organs. This can cause the rigid board-like abdomen. Again, yes, hepatomegaly, liver dysfunction, all kinds of ascites and swelling issues can cause distension, but when we're talking board-like, that's the literal lining of the peritoneal cavity. In fact, if you said, Mr. Fearon, the other day I had a patient who was experiencing a pneumo, they had board-like pleural cavity, I'd say, oh, maybe let's not use that phrasing. That almost always is used in referring to the peritoneal cavity. So in summary, and where these are often misconstrued or usually put as correct and wrong answers on the same question, gastroenteritis is largely self-correcting. You just get better. Your body kind of curves out of the problem. One of the major risks there is dehydration. What demographic of people are very susceptible to dehydration? Geriatric, right? Infants or pediatrics, are they susceptible to dehydration? They are, but for different reasons, right? Their stores are very low. So if they get dehydrated, it can have negative effects on them. Not because their body can't handle it, but they're just easily affected by it because they're low stores. Now, peritonitis is the life-threatening one. If you've got widespread inflammation of your peritoneal lining, that's a major issue. Lynn?
Are there any other causes to peritonitis other than ruptured organs or sepsis?
Not to my knowledge. You had mentioned something about like black widow bites or something. Yeah, but I think that's because they're neurotoxic or something. Yeah, but so I don't know. But again, that's just more like the rigidity. I don't think it's peritonitis. Now with UTIs, you should know that we call urinary tract infections, but you can technically be one of those guys that pushes up your glasses and says, actually, if you really want to. Now, if you have a urinary tract infection that involves your bladder, that's referred to as cystitis. Cystitis doesn't have anything to do with cysts, if you will. It has to do with whatever the etymology of bladder is, like Cesius or something. I don't remember. If you have a urinary tract infection in your urethra, they call that urethritis, which is much easier to remember. If you have an infection that has now gone all the way to your kidney, they call that pyelonephritis. I don't remember what the pylon part means, but the nephra is referring to the kidneys, the renal system. All I mean to say is make sure you have some exposure and association to this. Pyelonephritis is a kidney infection and might have been from a UTI. This is kind of involving what we might call an ascending pathology, right? You get a disease process at just the tip, and then it starts to kind of crawl its way up, boys and girls. Think about it like getting a respiratory infection because you get a sinus infection. Gravity's taking it down in this case. The reverse of that might be is that you get inflammation or an infection essentially at the end, and then it kind of works up your urethra, then it works up into your kidneys. And having a problem in your bladder is not good, but having a problem in your kidneys is far worse. Lower UTIs might climb higher, right? These are going to cause things like dysuria. What does that mean? It means painful urination, and as I have always known and didn't learn yesterday, burning. Pain and burning is what dysuria is.
What would be lack of?
Auria. No, I think it's oliguria.
What's the one for difficulty urinating?
I don't know. Somebody Google oliguria. O-L-I-G-U-R-I-A. I don't know what difficulty urinating is. Sorry. But frequent urination is a result of a UTI. Now it's important to note, this is not polyuria. Can anybody make the differentiation here between the frequent attempts to urinate and polyuria? Amazing. In polyuria, who's getting polyuria? Diabetics, right? Or at least hyperglycemic patients. Polyuria refers to the large quantities of liquid leaving them, whereas with you get cystitis, it's just engaging your receptors, making you want to have to pee a lot. Not necessarily that you're creating more urine. You just get the urge and sensation more. It might come with cloudy, foul-smelling urine and also suprapubic pain. Be careful here because, yes, the pelvic system and the abdominal cavities are different, but patients will just call chest pain when it's really upper abdominal. They'll call pelvic issues stomach issues when really they mean lower abdominal and not stomach at all, right? So these lines get kind of blurred. Pyelonephritis, which is an UTI in the what?
Kidneys.
Kidney. Which one? Yeah, either. I don't know. Now, this can come with flank pain. Why flank and back pain with the kidneys? Because they are retroperitoneal. In fact, if I've got a patient with flank pain, not necessarily the sides, though that's possible, but the flank, dude, there ain't a whole lot there that isn't a muscle, a bone, or a kidney. So if you've got pain here, I want to immediately talk about your pee. Right? How's your peeing going? This can come with all kinds of things. I mean, look, you can get a UTI and then die from it, for sure, right? Your body becomes septic and then you go out. I don't think that, I used to have a joke in the field, essentially, wasn't particularly funny, it was just very true, where I'd say, it'd be like, yes, I'll show you en route to a 65-year-old, I'm like, UTI. Like if you, go ahead.
Why is it that a lot of specifically older women in days from what I've seen will have a completely different complaint and not mention anything that makes you think UTI and then it's definitely
Yeah.
UTI. Like, I don't understand. Every old lady that I've seen.
Dude, it's like you've been a medic for 10 years. I know. So she's asking the question essentially why geriatric women specifically often have UTIs and why their signs and symptoms and complaints are not UTI and urinary related. There are other issues. Now, I have a suspicion that one of the number one causes of UTIs is just poor hygiene, right? Now, it is frequent, and it's especially frequent with both females, because if you didn't know, it's much harder to be a girl in many ways. And it's also more common with geriatrics because they have a harder time reaching, washing, and just generally keeping care of themselves. Put pretty simply though, as with women having a lot of different exterior genitals and a shorter urethra, the pathway is very short. And so women are far more susceptible to getting UTIs because with me, I've got an enormously long pathway before it gets to the kidneys, you know? Because the ureters.
Yeah.
Okay. Go ahead, Landon.
What does CVA stand for other than cerebrovascular?
I'll show you. It's the costovertebral angle. It's just like one of your, basically it's one of the last ribs here. You can pound on it and if it hurts, but just like Murphy's, there's no like fascinating science here. It turns out when you jab the organ that's hurting, that's the organ that's hurting. Yeah. Yeah. So if I go to your flank and I pound where the kidney is and you're like, yeah, that was it. I'm like, oh, I've got to solve the puzzle. But again, to answer your question, I think not just about why girls and why geriatric, but more to the point of why the symptoms is, man, I think because people are used to urinary issues, especially as geriatric and especially as geriatric women, that it's not all together. Dude, once I hit 40, it's all my friends talk about is their bodies and how they feel all day long. It drives me crazy, right? Like, I'm like 25 or whatever. I'm like, ouch, my knee hurts. The next day, I'm like, hey, did you see the latest movie or whatever? But now I'm just like, how you doing, man? They're like, dude, tired. And my knees and my back. And I'm like, I always try to remind them, I'm like, when you are 60, you are going to reminisce about how good you felt at 40. Just think about that as you complain, you know? Anyways, yeah. Also, a lot of it's lifestyle because, you know, there's all these buddies come down from Michigan who are stoned 25 out of 24 hours of the day and are sitting at their computer the whole time and are grossly overweight. And they come to Georgia and they're just like, dude, being 40 sucks. I can't remember anything and my body hurts all the time. And I'm like, we are having different experiences and I'm older than you. Anyway, costovertebral angle. That's essentially pounding on a kidney. Now, UTI causes, like I said, largely poor and hygienic. Does anybody know what the phrase iatrogenic means? Did you say Foley? Good job. No. Idiot. No. It means we did it to them. It's when a medical treatment causes the issue, iatrogenic. If you have a Foley catheter, you are getting a UTI. You'll be delighted if you don't. My wife is always, because she's always had a small bladder, always had to pee so frequently that she's legitimately talked about just like getting a Foley. And the reason she doesn't is because it basically guarantees an infection. So you're going to run calls all the time with people who have these symptoms and these presentations if they have a Foley catheter, which means urinary catheter going up the ureter and depositing in the bladder to just drain liquid out.
I like this truth. That's what I'm going to ask. My mom always say, don't hold you
So hopefully, go to the bathroom, you're going to have an infection.
There's something about that in the book. Yeah, it was talking about urinary retention, and I wondered. I was like, does that mean literal holding it? Dude, my bladder go long, dude. I mean,
But I think it's like more for us, you know. It's like you
Hispanics?
have to pee all the time because there's less retention. I don't know, and it's like we hold a lot, you know.
That's not my experience, but there is probably some truth to holding your bladder, your urge to pee unnecessarily, because it's largely an organ that involves stretch receptors. And if you're just ignoring it saying, hey, 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 like I'm signaling, that might have some issues, but I don't know. I pee when I gotta go. What up?
I think it's more like because they can't empty it all the way. It gets some bacteria in there.
Oh, okay. Shannon is talking about that the urinary retention isn't Alanis. Shannon was talking about that she thinks that the book's reference to urinary retention is less about, resisting your urge to pee and more about keeping urine a liquid in a place for long and then culturing up bacteria. I think that's pretty astute. I do too. Now, we can have a UTI cause all kinds of issues. It's going to ascend, climbing all the way up, right? One tube connecting to another, leading to an endometriitis, right? Talking about our uterus and various things. I'm an ally. And then possibly involving peritonitis. I'm just co-opting feminine anatomy. Don't worry about it. Now, pelvic inflammatory disease. This is going to be one of those things that can be dangerous and deadly, but has some specific giveaways that might help us differentiate it from ectopic and all number of other things. Let me get a quick check here. I wouldn't say we're doing well, but we're not doing the worst. Now, the number one cause of PID is sexually transmitted infections. I point because you corrected me, not because of any other reason. She's just a smart girl. But that's what we call it now, and I think it's to take the sting out of the phrase disease, and also, it's not a disease, it's an infection. So there we go. A major cause of this is post-stuff, postpartum, post-surgical. If you get something moving around or moving out of you in those cases, it can cause a disruption of tissues. That joke will write itself. And it can lead to many other issues. Look, pelvic inflammatory disease essentially is an inflammatory disease process of your upper reproductive organs, and specifically female, meaning your uterus, your fallopian tubes, and your ovaries. That will scar them up, and it can therefore lead to infertility and puts you at a much higher likelihood for ectopics, because much like your vasculature, when it gets atherosclerized and becomes far more likely to accept and build clots, so too could those tissues be accepting the clots in the wrong, not clots, babies in the wrong spot. Goodness, we got through it. Now, what's important about this is that as it trains up, it is rarely unilateral, right? You've got a woman during what's the childbearing age? 8 to 80. Who has bilateral pelvic pain. A part of us is like, phew, now I just got to worry about sepsis. If it's hurting on both sides, and I think it's reproductive in nature, I'm like, okay, well, at least we're not talking about an ectopic. There's no universe you get essentially an ectopic pregnancy on both sides, right? So we're talking about left lower quadrant, right upper quadrant abdominal pain. But again, be careful with this, because yes, they're pelvic injuries, but they're largely in abdominal areas, right? And certainly will be referred to by patients that way. You can get vaginal discharge as that inflammatory process and infection starts to really cause an issue, and you can get dyspareunia. What is dyspareunia?
Painful intercourse.
Painful intercourse, right? Which you're less likely to get on, say, UTIs. And that can be a way to kind of differentiate it, largely because one is urinary, the other is reproductive. And if you don't know this yet, boys, they are distinctly different areas. Open your book, you'll see. Now, you hear me talk about comparisons all the time, and I did one for you here. Look, my next course is going to have 1 million of these things, partly because I like them better, but mostly because I just don't have the time to make all of the things. But this is how you should study them for sure. Pull out and extrapolate the isolated things that helps you differentiate from the others, and here's a way to get you started. The number one thing with females and abdominal pain is thinking, okay, is it ectopic? No? Whew, lovely. Is there any chance you're bleeding in a hemorrhagic issue? Or could it be sepsis? Those are our next questions. But the first is ectopic. And here's some of the things you're going to confuse them with. It's when I go to write a question about ectopic pregnancy or a kidney stone, I'm going to put answers like PID, UTI, and ectopic because they're all so easily confused for each other. Big distinctions here are highlighted. Sudden, sharp, unilateral pain as opposed to bilateral, dyspareunia, dysuria, frequent, cloudy, hematuria. What's hematuria? Bloody urine, right? All kinds of different situations. With pelvic inflammatory disease, that's not something that happens overnight. It's something that takes a gradual onset. With a UTI, it's not reproductive, it's urinary. And so for questions about their last in and out are going to become far more important. Period timing, though it don't go into this like, to kind of see through the matrix here a little bit, like this is an abdominal and renal, if you will, and urinary test you're coming up on, not a female reproductive one. Which means, yes, ectopic might be the answer sometimes, but it's more about do you understand the urinary and renal system, not do you understand female reproductive. That comes later, right? And in my case, much later. Now, in your book, you'll see stuff on ulcerative colitis and Crohn's. I'm going to do my best to remember not to include anything about that on the test because we have Thursday is a literal disease day where I just am like, look, you're going to registry soon. It's time to talk about all the diseases, right? We're talking about respiratory, we talk about cardiac and cardiac arrest. Those are huge. Those are the number one things you have to know. Lungs and heart stuff, great. Then we're talking about trauma. That's another very big one. And then I'm like, look, let's shore up. Remember hepatitis? We talked about that a bit. Let's talk about meningitis again. That's your infectious disease reminder. And we go into Crohn's and ulcerative colitis a little bit more. Let's kind of end our discussion-ish. Dude, it's so funny. I've included aortic aneurysm on because we never get to it. I'm like, it's like, it doesn't even really belong here, but I tried to steal it thinking, God, if I have time, which, because I always have an abundance of it, we're going to talk about it. Yet again, we find ourselves without much time to talk about it. Now, kidney stones, these are also referred to as renal calculi, right? I've seen them phrased that way, so be aware of it. Usually, you're getting these obstructive glass-like fractures in your pee hole and kidney and ureter. It's not fun, despite what Henry says. Usually, it's an excess of uric acid or calcium buildup. High salt diets somehow affect it. I don't know why. There's also a link between family history, but a lot of what causes kidney stones is still a bit of a mystery to us. I put reference here to show you and remind you that it's not just little rounded river stones. We're talking about these things with hands and teeth. So depending on the type of it, you see how this one's kind of shaped, if you will? The reason it's shaped that way is because it took place here and started to grow into that. They've kind of extrapolated some of these kidney stones, and you can see it like the inside of somebody's kidney because it's just calcifying in the area. They're deeply painful. If I had a suspicion that a patient of mine had a kidney stone, I would get them so high, so high. But they can present in a million different types of ways. Flank pain is the dead giveaway, right? Now, if I think flank pain, I'm thinking it's either in your kidney or it's in your ureter. And a lot of times they build big in your kidney and then get to your ureter and can't fit, and that's an issue. And then only if you are the manliest of men do you pass it beyond that. Now, it can radiate all over the place. I've had back pain, shoulder pain, not me, thank God, but I've seen people. I had a young man once who was complaining of left ball pain. I was like, all right, well, what was her name? He's like, no, it just happened out of nowhere. I said, were you doing any workouts? I think an epididymitis or a torsion. Nothing, dude. He woke up. He was like, ouch, my left ball. And I said, okay. He said, do you think it'd be a kidney stone? My mom has kidney stones. I said, ha, 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 no. Not in the ball. No. That's not how urination works. Anyways, we go to the hospital. He says, hey, can I use the bathroom? And like I always said, I said, yo, go ahead and take a urinary cup because the nurses are going to want you to pee in it and you don't want to have to do it twice. Guess what happened? No, he had cancer. He died like 2 days later. I was right. Ha ha ha. No, not really. He come out of the bathroom and he was like, and I was like, hey, you came out a different human. He's like, dude, I feel great. He said, also though, I heard a click when I was peeing and there's just this tiny little stone in there. And I was like, I'll be darned. Right? So I guess all I mean to say is that if you see flank pain radiating to groin and testicles, look, that's the pathway from kidney, ureter, and to the urethra, male and female, right? But it can come in all kinds of presentations. Can anybody, based on the pictures, tell me why you might get hematuria? Do you think it has anything to do with the razor blades? Yeah. Good job. We solved it. Now, you also need to know that if I've got a mechanism in there, dicing and slicing, right? Is this helping? I don't know.
Making me remember.
Takes me back. That we can have pyelonephritis. You can get inflammatory and infected issues because you're slicing up your urinary parts. Yeah.
Do they just like get them high until they pass it?
Ideally, yes. Ideally, they get them high and then they pass it. But if that's not working, they'll do what's called lithotripsy, which is essentially just sound waves that shakes it up, breaks it into smaller pieces, and then they pass it. Now, sometimes they have to go in surgically with this little like catheterized like thing, go up in there, right? Grab 2 fists and then get in there and pull the pieces out. But most people will pass these stones regrettably. Those that don't, they have to go in for a sound treatment, the lithotripsy, to break it up. And even rarer still, sometimes it gets so big, it will never pass and won't get broke up by just a cute little, 80s soundtrack getting played through an electronic device. They have to go in there and cut it out. You might lose a kidney because of it if it gets so big. But getting high is definitely happening for the patient. Now, another obstruction is your bowel obstruction. And I will never forget showing up to a person saying, hey, I've got a bowel obstruction. And I was like, oh yeah, you get them frequently? And they're like, definitely. I was like, okay, because that was an odd kind of immediate conclusion to jump to. And she says, I even did what my mom, you know how like your mom tells you, like if you can kind of dig up there and pull it out, just to kind of clear the way? I was like, we've had different growing up experiences for sure. I was like, sweetie, I really don't recommend you put really anything in there. That's not medically sound. But this will involve a lot of issues. An obstruction can kill you dead for sure. Put pretty simply, if you can't get rid of waste, then it builds up in you, right? It becomes poisonous. In fact, that's what they used to do with what's called punji sticks. It's a good idea if you're defending a fort to put up a wall. But people are going to want to climb that wall. And so one cool thing that we can do is cut a bunch of sticks so they're pointy and put them in a hole all the way around. So now if they fall in that hole, they get stabbed. The problem is those little sneaky fools, they get stabbed a little bit and then come climbing out and revisit the idea. Turns out, if I take a handful of my own boo-boo and I rub it all over that stick, now that cut poisons you, right? The point is, poop is bad. Let it go. I know it's a part of you, but let it go, okay? Now, it's not just the food that can't get out and the poison that's building up, it's the gas and all that different stuff. If you get enough inflammation and enough pressure in that area, you can have mesenteric artery ischemia. Your tissue can die and that can kill you. But here we are again, leading to an internal hollow organ, causing a major issue and leading to peritonitis. Can anybody tell me why a person might have fecal odor on their breath that make you suspect bowel obstruction? Yeah. I have not run a call on it, but I have had a few buddies who were like, oh, what did you eat? And they're like, nothing. I haven't been able to eat for days. And it was just backed up so far as to come out the mouth. Ow. Anyways, good luck on aneurysms and dissections. Yeah. Oh, a correction. You see how this says dissection, the bottom says aneurysm? I noticed in the last I didn't realize this said aneurysm. It's not aneurysms that cause the difference in blood pressure. It is dissections. Make sure you know your bloods. One of the major confusions here is people are like, oh, blood coming from your rectum is hematochezia. And I'm like, no, it can be two things. It depends whether it's bright or dark. Number one cause of peptic ulcers is? Uh-oh. That is probably number 2. Ibuprofen prevents the prostaglandins. H. pylori. Don't forget it. Make sure you know about esophageal varices, that you can differentiate Mallory-Weiss from varices itself. Again, we'll talk more about ulcerative colitis and